Hi guys. Welcome. I want to introduce Bridget Doyle. She's one of our dietitians. She's going to be teaching us today about nutrition in hospitalized patients. So take it away.
Okay. Thank you guys for coming. Thanks, Magda. I want to thank Magna for having me. Like she said, my name is Bridget Doyle. I've been a dietitian here at Loyola for the past 7 years. I actually started in general medicine back in 2014, and then have kind of moved over into ICU care starting in 2015. And then for the past 4 years, I have covered the cardiothoracic ICU, lung transplant, and cystic fibrosis populations, both inpatient and outpatient. Okay, I have no disclosures related to this presentation. And so these are objectives of today. We're going to start with just understanding how acute illness affects nutritional status of our patients, as it's obviously going to be different than our healthy, non-hospitalized outpatient. And then going down the line, understanding the diagnosis of malnutrition, different feeding modalities between oral supplements, enteral nutrition, and parenteral nutrition. And then finally, at the end, I hope you guys care about nutrition a little bit. A lot of what I will focus on today is going to be more ICU level care, which I know you guys rotate through, but a lot of it is transferable to the general medicine floor population as well. Okay, so before we even go into nutrition in itself, I think it's important to take a brief step back and remember the physiological changes that occur when anyone comes in with any sort of injury, infection, or some sort of acute illness, because that's going to result in a poor nutritional status and lean body muscle loss. And so our nutrition stores and how our body uses nutrition varies based on the state that our body's in. So in starvation, there's no physiological change that's happening. So really this is only from either, poor oral intakes from a socioeconomic reason, mental health issue, or eating disorder. And the starvation etiology of poor nutrition status is reversible with feeding. On the other hand, when we have stress or injury, there's going to be more physiological changes going on in the body, driving the loss of nutrition stores, utilizing stores that the patient already has for energy to respond to this infection or inflammation. And with this, what happens is we do provide nutrition, but it's not necessarily going to reverse the already catabolic state that the patient's in. Okay, so here is a nice diagram taking you back to what happens in inflammation and in gluconeogenesis. And so during injury or illness, we do see alteration in all of our metabolic and endocrine pathways. So we do see an increased insulin resistance. And then we also see hepatic reprioritization of protein stores. And so what happens when our patients come in, and if they're NPO for even just 24 hours, most of their glycogen stores are going to be depleted. That means the body is going to start demanding energy or glucose from other stores such as protein and fat, okay? And so we have that gluconeogenesis cycle happening. And the problem with this is that some of our organs need that glucose for energy. We can't depend on fat alone as an energy source. For example, our brain, our central nervous system, they use up to 80% of our hepatic glucose production every day. Red blood cells, white blood cells, bone marrow, they also are dependent on glucose for functioning. And so this increased glucose production via gluconeogenesis and then the decreased insulin secretion leads to that hyperglycemia that we see in most of our patients, especially our critically ill patients. Hyperglycemia is correlated to increased infection risk and poor wound healing, which is a big thing that's a focus in the Trinity Health system right now. Okay, and so all of this leads to that lean body mass or muscle loss, which has been correlated to increased risk of mortality, increased hospital length of stay, and increased ICU length of stay. And patients with organ failure can lose up to 15% of their lean body mass just in the first week of hospitalization, which is quite significant. And in some studies in ICU patients, when they're kept NPO for 5 days, they lose up to 3 kilograms of muscles in those 5 days. And I don't know if any of you have rotated in ICU yet, but you'll see how quickly these patients become debilitated. And so we have the physiological stress like we talked about, and then we have other reasons that they lose their muscle, right? They're not as mobile as they were before the hospital stay. We have interruptions in nutrition delivery. And then some of them come in with pre-existing low muscle stores, whether they have sarcopenia, they have chronic illness, or other etiologies for this muscle loss. So how do we measure muscle loss? This is the ongoing debate in the nutrition world, is the best way to measure these muscle changes. As dietitians right now, and just like physicians, you kind of do that bedside physical assessment and exam to look for any muscle wasting or changes and talk to the patient about it. This is just more convenient and a low cost. Objectively, there are different measures out there that we can perform. It's more so used in research, not as much clinically right now, to measure muscle stores, such as DEXA scans, bioelectrical impedance analysis, MRIs, or ultrasounds, among other things. And on this slide, you can see the results of a study, a smaller study that was done at Cleveland Clinic in their SICU population a couple years ago. It was about 50 patients were included. And they took quadricep muscle layer thickness measurements. And so that kind of the measure at the midpoint of the quadricep, they took ultrasounds 3 times within the first 10 days of admission, okay? And they measured how much muscle loss occurred each day. So on average amongst the patients, they saw that 3.2% muscle loss occurred every single day in these patients, despite them being fed, despite them being provided the nutrition support they needed. And this is just an ultrasound of one of the patients in the study, the first measurement, and then the third measurement, which was about 7 days later. And unfortunately on the slide, you can't see, but on my screen, there's a red line in the middle that kind of shows you the difference in the muscle thickness between those 2 ultrasound studies. And that, what they found in that study, although it's not statistically significant, it still is clinically significant. They found the people with the most quadricep muscle loss were the ones who were diagnosed with malnutrition by a dietitian, those who had higher body temperatures, and then also those whose nutrition support did not start for 3 or more days from admission to the ICU. So all this leads us to talking about malnutrition, which probably starting 5 or 6 years ago has been a really big topic in the hospital setting and kind of in the Medicare world. And so why should we care about malnutrition? As you can see on this slide, malnutrition is associated with many negative outcomes, impaired immune function. Difficulty weaning from the ventilator is a big one, especially in our ICU patients. Increased risks of morbidity and mortality, and higher healthcare costs overall. And then again, talking about wounds, and this is a big thing that we want to prevent in our patients, or infections. Those with malnutrition, 4 times more likely to develop pressure ulcers, 2 times more likely to develop surgical site infections, 16 times more likely to develop intravascular device infections, and then 5 more times more likely to develop catheter-associated UTIs. And then lastly, just, when I mentioned healthcare costs, malnutrition is associated with higher healthcare costs. In one study done locally in the Advocate Healthcare System, which I'm sure many of you are familiar with, they saw that optimizing nutrition care resulted in a savings of $3,800 per patient. Obviously, as providers, we don't always see these costs, but that's quite significant for an individual patient. So true or false, hepatic proteins such as albumin or prealbumin can be used to assess the degree of malnutrition. Any guesses? False? Anyone else? False? Did I make it obvious? Okay. Yes, false. So unfortunately, we cannot use albumin and pre-albumin to assess nutrition status. I wish it was that easy. I really do. In outpatient setting, again, a healthy individual, yes, that is a good marker of nutritional status. But in our inpatient setting, with our inflammation infection, albumin and pre-albumin, along with others such as transferrin, are negative acute phase reactants, right? So we're going to see decreased serum levels in this patient population. On the other hand, we see that inverse relationship with positive acute phase reactants, CRP, ferritin, amongst others. And why do we see these decreased albumin levels? There's many physiological things going on in our body. One is that there's decreased hepatic synthesis of albumin. This is a low priority process for the liver, and it only is going to occur if there's adequate nutrition stores. Otherwise, it's going to kind of be put on the back burner as a priority. We do see movement of albumin into extravascular spaces due to increased capillary permeability. And then we also see intravascular fluid overload that's masking those serum levels. And so some studies have shown in abdominal and thoracic surgery specifically that CRP, so again, kind of telling us the degree of inflammation or infection levels, peak post-op day 2 or 3 after surgery. And then we see a gradual decline over the next couple of weeks after surgery, which you guys can kind of see on this graph that was taken from one of the meta-analysis that I pulled, measuring CRP amongst other labs. And so as dietitians, how can we assess for malnutrition? Obviously, we don't have that lab. And unfortunately, we don't really have any objective lab markers to use. And so it's a combination of subjective and objective data. So first is obtaining a nutrition history, right? Just as you guys obtain a history when a patient's admitted, we're going to ask about how were they eating? Is it their baseline? Was it significantly less than normal? Were there any GI issues that were affecting their PO intake or appetite? Okay, any diet restrictions, any supplementation, whether it's vitamin, protein, whatever it may be. Then we will kind of assess weight changes. Weight changes are a really good measure to assess someone's nutrition status, because we're going to see, if it's unintentional, it's going to be more acute weight changes. And so we like to get this subjectively from the patient, but then we also like to kind of cross-check it objectively with the information in the chart, because some patients don't always have the best insight into their weights, or maybe they aren't checking them at home. And then we are also obviously looking for weights that may be inaccurate, whether there was fluid shifts or hypervolemia, or whether it was just different scales or bed scales. Bed scales are something we really commonly use in our ICU populations because our patients are unable to mobilize from the bed. Unfortunately, bed scales, in my personal opinion, are rarely accurate. I'll see 20-pound differences in 24 hours on them, unless the nurse was able to zero it before they use the bed scale. And then the nutrition focused physical exam, again, assessing for fat and muscle wasting, okay? And so BMI in itself is actually not a criteria for malnutrition, is not recognized as a diagnostic factor for malnutrition. You can definitely have overweight or obese people who are malnourished. Those are a little more difficult to assess because you're not going to see that muscle or fat wasting as obviously, but it's a common misconception of, oh, they're obese, they can go longer without nutrition. Because they're still just going to be using their muscle stores more than anything. And then you can have someone who's underweight and be totally nourished. I'm sure many people know people who are just thin, and that's their baseline, and that's okay too. They aren't necessarily malnourished just because they have a low BMI. Okay, and so criteria for diagnosing malnutrition. So there's 3 types of malnutrition. We have the starvation-related malnutrition, which I kind of talked about, that can be reversible with nutrition. We have chronic disease-related malnutrition. So that's going to be something that's occurring for greater than 3 months. Okay, so it's something that's more chronic, whether it's organ failure related. We see a lot of it, like cardiac cachexia in our our heart failure population. You could have it because of some certain autoimmune diseases, or cancer is a really common one where we'll see this in. Unfortunately, with chronic disease malnutrition, we can give nutrition interventions to try to slow down the muscle loss or the malnutrition progression, but most of the time we're not going to be able to stop it. Okay. I kind of tell when I teach students, dietetic intern students, I kind of tell them is like, think of filling a gas tank in a car that has a leak in it. Okay. We're going to give it some, but we're never going to be able to restore it completely. And then acute disease malnutrition. So again, just like I said, more acute usually is going to be acquired within the hospital stay or shortly before the hospital stays. It's usually from a certain event, whether it's a trauma, injury, things like that occur. Okay, there we go. And then these are the criteria that fall under those etiologies for malnutrition. As dietitians, if we're going to diagnose someone with malnutrition, we have to have at least 2 of these criteria to diagnose the severity of that malnutrition. Currently, mild malnutrition is not recognized as a diagnosis in adult population. It is used in the pediatric population. Okay. So how can we slow down this catabolic response? So we kind of talked about why it happens, different degrees of the nutrition status. And so I'm not going to be able to go through everything in detail today, but I'm going to really focus on enteral nutrition, talk about diet and supplement management, and then briefly touch on parenteral nutrition. Okay, so enteral nutrition, I'm sure many of you have come across it in your schooling, but that's going to be any liquid form of nutrition given through a feeding tube. And there's different methodologies of giving enteral nutrition, okay? And so trophic feedings are anywhere from 10 to 20 mLs per hour. So that's maybe just starting to see if someone's going to tolerate the tube feedings. Someone who's had high refeeding risk, that might be an appropriate thing to do as well. If you think about it, 10 to 20 mLs is very, very minimal. 30 mLs is 1 ounce, right? So 10 mLs is less than half an ounce, I say less than half a shot glass of volume per hour infusing in a patient. So I have some people freak out when I say, oh, I want to give 90 mLs an hour. That's 3 ounces. That's 3 shot glasses over an hour. That's really not that much volume. Continuous feeds, just like it says, it's the first circle here, runs continuously. It's going to be the best for patients that we're kind of upping the tube feeds for to see if they tolerate. And then also our ICU patients where we don't want to give too much fluctuation in volume and fluid just because of their hemodynamic status. Cyclic feeding, so that's anything less than a 24-hour period, whether it's 20 hours, 18 hours, whatever it may be. Most of the time, it's going to be what we call nocturnal feeding. So overnight, 8 to 12 hours. We use it a lot as supplemental feeding to allow the person to eat during the day. And it's a good way to transition from full enteral nutrition support to PO diet alone, where we can kind of monitor their intakes and decrease the tube feeds as they're improving. Usually we can stop tube feeds when someone is meeting like 50 to 60% of their needs PO. Intermittent gravity feeds. So the top 3 use a feeding pump. The intermittent gravity feeds do not use a feeding pump. It is simply gravity. We pour it into a bag. Gravity will drip it through the feeding tube. These usually last 20 to 60 minutes and it's scheduled like meals. So it might be 2 cartons at breakfast, 2 at lunch, 2 at dinner, or something like that. And so this is a really nice regimen for patients to go home on because it's more realistic for life. And then lastly, bolus feeding. We don't use this too much in the hospital because it's a large volume given really quickly. It's just administered via syringe. Sometimes we'll do it in patients who have no GI issues or in patients who don't have coverage as an outpatient for tube feedings because the bags and the supplies are expensive, but syringes are pretty cheap. So indications for enteral nutrition. Obviously, there's going to be vast reasons why we provide enteral nutrition support. These are just general summary. So inability to take PO, right? So if someone has severe dysphagia, if someone has is on a ventilator, right? They obviously can't take PO, altered mental status. I have people in my lung transplant patients, I have people who have esophageal aperistalsis, absolutely no function of their esophagus besides gravity. We don't let those patients eat after transplant. They're strict MPO. So there are people who need enteral nutrition. Altered GI function leading to increased nutrient losses, right? So if you think of anyone who has a short bowel syndrome, who has history of any sort of gastric surgery, gastrectomy, or who has pancreatic insufficiency where they have a lot of malabsorption, such as my cystic fibrosis patients, that's something we utilize to try to make up for the calories that are being lost, the nutrition that's being lost. Poor PO intakes despite diet and medication adjustments. So, adjusting the diet, liberalizing it to give them more options, changing consistencies to what they can tolerate. Medications, trying appetite stimulants, things like that. That's going to be an indication to give nutrition support. Unfortunately, that in itself is not a qualifying diagnosis for coverage of tube feeds as an outpatient. Poor PO intakes or poor appetite will not get us coverage as an outpatient. They have to have a physiological reason why they cannot take oral nutrition for coverage. Inpatient, it's no issue. And then increased nutrient requirements for healing. So we see this a lot in our burn patients where they might need 3,000 plus calories a day to heal those severe burns. And so then we would use enteral nutrition support. Common enteral formulas at Loyola. So I did bring, for the people in this room, I did bring our formulary cards. So, feel free to grab it if you want, and I can always get more. It's just what I had available. It does list all the enteral formulas and kind of the nutrition content of the ones available at Loyola, as well as our nutrition's oral supplements. So these are common formulas at Loyola. I'm not going to go through everything in detail, but most of the time we start with our standard polymeric formulas. So, okay, so what that means is they're intact formulas, intact protein, fat, carbohydrates. So it really mimics a normal meal for an individual. And then we kind of have a degree of concentration. So we have our isotonic formula, meaning the osmolality of it is about 300 milliosmoles per liter, kind of matching the body's osmolality. When it says 1.0, that means there's 1 calorie per milliliter, okay? So it's going to have more water, free water in this formula. Then we can go more concentrated. So our semi-concentrated, like our Osmite 1.5 is 1.5 calorie per milliliter. And then our concentrated 2-cal HN is 2 calories per milliliter. So that one's going to have the least amount of water in it. We're going to use more concentrated, obviously, in patients who are worried about fluid. We're trying to watch our fluid in our heart failures, in our ICU patients, those with pulmonary edema, those we're trying to diurese. And so that's, as dietitians, we kind of, look at all those things, their hemodynamics, fluid status, lab values to determine what we need to use. Any of the formulas on this slide with an asterisk contain fiber. And so, sometimes we'll use that if it's indicated. We have high protein formulas such as Promote, where it's higher amount of protein per milliliter. We have renal formulas. So Nepro, NovaSource Renal. Nepro is our preferred formula. We're contracted with Abbott. That's just who we're contracted with. So these are the formulas that we use. But we will use NovaSource Renal if we don't want fiber in the formula. The only time you need to use the renal formula is if the patient has hyperkalemia or hyperphosphatemia. There's no other differences between that formula and a standard formula. And when we're worried about protein in people with AKI on CKD with rising BUNs, renal formulas actually have higher amounts of protein than our standard formulas. So as dietitians, we really only switch over to these formulas when there's hyperkalemia or hyperphosphatemia. Semi-elemental, so that means things are partially digested. Okay, so our proteins are now broken down into peptide form to allow for easier absorption. And then immune enhancing formulas, Pivot 1.5 is the one we carry here. These contain arginine and glutamine, which are conditionally essential amino acids. So they become more necessary during critical illness. And so studies have shown positive outcomes of using immune enhancing enteral nutrition formulas in certain populations, specifically surgical oncology, traumatic brain injury populations, and then traumas. There's still debates about immune modulating formulas in some other populations, especially sepsis, because there's concern about the arginine and its effect on nitric oxide concentration in vasodilation in these patients. And with any of this nutrition, when we're doing tube feedings, we're also thinking about medications that could decrease or increase the bioavailability. And then medications that provide calories as well. So like in the MICU, CVICU, CCU, we use propofol a lot as a sedation. And propofol is provided through a lipid emulsion. So it provides 1.1 calorie per milliliter. So as dietitians in the ICU, we're watching those propofol trends, talking to nurses about if we're trying to wean off, what kind of the plan is, because that's going to affect how much nutrition we give. Especially in these patients, we don't want to be overfeeding them on the ventilator. Okay, and then these are different types of feeding tubes. So again, not going to go into too much detail about them. Generally speaking, you're going to see the NG and the OG tubes a lot. Those are more temporary tubes that we will place. The only negative with an OG tube, it's really nice to place when someone's intubated. It's a little easier to access, but the only problem with that is we do lose that access upon extubation. So if we have patients who are extubated and then don't have access, that delays being able to transition to oral medications or to continue their nutrition. So most units, we do prefer doing an NG tube for our ventilated patients when possible. Nasal jejunal tube, so someone's going to need that post-pyloric jejunal feeding if they have any reason they can't tolerate gastric feeding. So if they're having emesis, if they have a history of gastroparesis, if they developed critical illness-induced gastric dysmotility, which we see often, those are reasons that we would want to trial feedings post-pylorically to see if they can tolerate that. Our PEG tubes, those are going to be our more, I used to say permanent, but patients don't like that word, more long-term tubes. Can be removed within a couple months, but these tubes are going to be placed by GI via EGD. They're our most common way to access long-term nutrition, indicated if we think someone's going to be dependent on enteral nutrition for 3 months or greater. And then surgical G or J tubes we can do, and then we can also do a combined GJ tube, which is one tube ends in the stomach space, one tube ends in the jejunum. We use these a lot, again, in those like kind of gastric dysmotility pictures where we have to feed post-pylorically, but maybe we need that G tube to give crushed medications through if they can't take PO. Crushed medications can't go through those J tubes. They're too small. They'll get clogged. So that's when we'll kind of do that combined GJ tube, or we'll use it for venting. So if someone does have severe gastroparesis, symptomatic relief is venting that G tube to let out air and any gastric contents that the stomach produces. Okay, so enteral nutrition in the ICU. So ASPN is the American Society of Enteral and Parenteral Nutrition. It's kind of one of our governing bodies for nutrition support. And then the Society of Critical Care Medicine, they published these great guidelines in 2016 regarding nutrition support in the ICU, and they're actually due for review. And next week, we'll get a kind of an update of what the new information is. But based on consensus and review of studies, they recommend that enteral nutrition be started early within 24 to 48 hours in patients who are hemodynamically stable and unable to take PO. And so this is early enteral nutrition, anything within 48 hours of admission. And what are the benefits of this? So we know it promotes protein synthesis, right? We're providing the body with nutrition. It acts as a natural stress ulcer prophylaxis. It lowers risk of infections, primarily by stimulating GI blood flow, but also by keeping those junctions tight in those epithelial tissues. So that, helps to at least decrease or prevent translocation of bacteria from the gut into the bloodstream. So that can really help with infection risk. And then it supports immunocytes that form the gut-associated lymphoid tissue. Okay, and then overall, we see it reduces hospital length of stay and mortality. And so this is just very brief consensus of studies showing the benefits of early enteral nutrition. Obviously, there's years and years and many studies out there. These are ones that I just felt like were good quality that I pulled through. So you can see publication type of study, number of participants and results, the benefits that they saw of the early enteral nutrition. Consensus-wise, we do see overall decreased infection risk and then decreased length of stay. In terms of mortality, it's kind of 50-50 on whether these studies saw an improvement or a decrease in the risk of mortality in patients in early enteral nutrition. And so, unfortunately, despite us knowing that early enteral nutrition is beneficial, it only happens about 50% of the time, or I would even say probably less than that. And this is for many reasons. It could be just due to, lack of knowledge by the providers, by the medical team, or just awareness, right? We all have a lot that we're managing. And this is just one thing, part of the whole patient's medical regimen. It could be concern for gut ischemia. So in our ICU patients, especially those on pressors, there's concern if there's adequate blood flow to the gut, and is feeding the gut going to encourage or put the patient risk for ischemia. And then, concerns for aspiration risk. Sometimes we don't feed them because we're concerned for aspiration risks or GI intolerance. And so talking about pressors and feeding on pressors, it's pretty universally accepted that it is safe to feed on vasopressor agents. And the University of Virginia produced some guidelines in terms of dosing for, and these are just for the pressors that are most common we see here, safe dosing of feeding enterally. These are just guidelines. Vasopressin is the one that we're usually most concerned about. And I usually won't feed above 0.04 units per minute because that has a direct effect on the mesenteric blood flow. Whereas epi, we don't really have that direct GI blood flow effect. I will say I covered the COVID unit all last year, and I've seen highest doses of norepi I've ever seen in my life. And we fed and we didn't have any issues. Of course, in any patient population, right? If they're critically ill, hemodynamically unstable, we're not going to feed these patients. Again, Aspen provided guidelines. We look at MAPS a lot as ICU dietitians. We're watching MAPS and pressor titrations. They recommend if MAPS are less than 50 to hold enteral nutrition. I feel like it's personally a little low. I usually say 60. Or if the patient is requiring escalating doses of pressors to maintain hemodynamically stable, to maintain their pressures, is another time that we would want to hold the nutrition. Preventing aspiration. Many studies have shown it's safe to feed, and these are just different ways to help reduce the risk of aspiration with raising the head of bed. Obviously, one supine, 30, 45 degrees. When prone, put them in the reverse Trendelenburg position, so 10 to 15 degrees. It is safe to feed a prone patient. You reducing the level of sedation, and then you can consider post-pyloric tube if it's really a high concern or if they have a history of aspiration pneumonia. Gastric residual volumes. I only bring this up because in studies it's mentioned as a sign of GI intolerance. It's really not practiced much anymore. As they found, and again, these are based on guidelines, that it doesn't correlate with any adverse events. So it doesn't correlate with pneumonia, regurgitation, or aspiration. And it led to more cessation or holding of tube feedings, misnutrition, taking up nurses' time, and tube clogging. So for anyone who doesn't know what gastric residual volumes are, nurse taking a syringe, pulling back on the tube, seeing how much comes out. And historically, if it was like even 200, sometimes they'd be holding tube feeds for that. When I think about it, I'm like, well, we're feeding the patient, we're giving medications, and our stomach produces 1 or more liters a day of just content, gastric content. So in my head, it makes sense. There's going to be fluid in their stomach to some degree. Per Aspen guidelines and then Loyola's policy, we do not check residuals here. Some units still do utilize it. And if they do, we do recommend only holding tube feeds for greater than 500 milliliters. If you're having that much residual, then maybe there is some issue with motility or obstruction or ileus going on. I don't quote me on this, but I think like the burn unit and I think bone marrow transplant will still utilize residuals. But I think most other units have gotten rid of that policy. And then assessing tolerance to enteral nutrition. Okay, so it's different issues that can occur. Abdominal distension, pain, right? One thing I always ask, when's the last time they pooped? My team calls me the poop police. I like to make sure my patients are pooping. And so Are they on a bowel regimen? Have they had a bowel movement in the past 48 hours? Imaging, of course, is going to be a great way to tell. This is an x-ray of one of my CFers. She's a chronic constipated patient, and you can see that all that cobblestoning is some stool buildup on her x-ray. And then nausea or emesis, right? Is it medication induced? So you guys all know there's medications that can cause nausea. Do they have some degree of delayed gastric emptying from their critical illness in itself? If that's the case, maybe we try that post-pyloric feeding, or maybe we try pro-motility agents such as metoclopramide or erythromycin. Constipation again, or ileus, amongst other things. And then diarrhea. This one gets its own slide. Like I said, I'm the poop place. So, the definition of diarrhea is technically 3 or more liquid, watery stools in a 24-hour period. However, bowel movements are very subjective based on the person who saw them. And so you can have someone who was fine one day and then the nurse next day is saying, oh, they have diarrhea, right? And so we have to look at trends. One of my pet peeves is that when, automatically it's the tube feeds. That's the first thing to think. Oh, it's the tube feeds. That in itself usually actually isn't the cause. I do expect loose stools with tube feeds. We're providing them just like liquid nutrition, right? Think like a milkshake continuously. So I do expect loose stools, but we should really make sure to rule out any infectious cause first, right? So C. diff is a common hospital-acquired infection. We should be ruling that out. And then in certain populations, such as transplant patients, who are more prone to infectious complications, things like CMV or norovirus are going to be important as well. I was just thinking last month, I had a patient who was in my CVICU, a COVID patient on ECMO, and he was on the same formula for 4.5 weeks, a semi-elemental, so semi-digested formula, doing fine, no issues. He developed like diarrhea over 48 hours. And the first thing they said, stop the tube feeds, it's the tube feeds. I didn't like that, obviously, because he was on the same formula for 4.5 weeks. I don't think it was the tube feedings. So that's something, just, touch base with the dietitian. We're monitoring that, or look at the trends, not just one timestamp for these patients. Medications, right? Antibiotics, we know that can cause diarrhea. Reintroduction of SSRIs, Zoloft, things like that, that can cause GI distress. This is just this very small, because it's all I could fit on medications. There's, tons of medications that have these side effects. And then sorbitol containing solutions. So any of our medication suspensions that are in liquid form, they can contain sorbitol, which can exacerbate diarrhea. The other thing I like to ask, especially my CV population, where they're put on a bowel regimen right away post-op, and then they stop it all because they're having loose stools, is when's the last time they had the laxative? If they had Miralax last night at 2100 and it's 7 a.m. today, okay, we might have some residual effects going on. And then lastly, if those kind of have all been looked at and ruled out, we look at the tube feeds. So, we can look at fiber content. Should we try formula with fiber? Without, most tube feed formulas are mixed fiber solutions, both soluble and insoluble. Osmolality, so I mentioned earlier, some formulas are more isotonic. So those are generally going to be more tolerated, versus a 2-cal formula is going to be more hypertonic. And then digestion. So is it an intact formula, or should we try like a semi-elemental or an elemental broken down formula? And so most physicians I work with, because they have so much to manage, right? That's why we're here as support, is to help manage components of the patient's care. Most are surprised in the ICU how little nutrition their patients are actually getting, despite the order just being in. This is a case recently I had of a MICU patient that was chilling in my unit, that, came in with severe malnutrition, had been at outside hospital with who knows how great of nutrition, came in on the 18th, intubated, tube feeds were started on the 20th via an OG tube. He was extubated at 21st. We lost that OG tube access. Bedside swallow valve on the 22nd, NPO, put the Dopphoff in. And then he was transferred back to ICU on the 23rd for worsening hypoxia and on Optiflow. And due to concern for his respiratory status, was not started on nutrition yet at that time. And so overall, when I looked back, his goal was to get 13, 20 mLs of tube feeds a day. And down here, you can see what he was getting each day and how many calories that was. So average over 5 days, he was getting average 110 calories per day, which I don't know. I could not survive on 110 calories per day. If I was awake, I would not be happy. So that's nothing. And that was only 5 days. This is a kind of like a minimal case. I was even looking today. I have someone in my CV unit right now who since June 22nd has gotten 120 calories per day because he's been NPO almost every night for a procedure the next day, whether it be a bronch, a scan, for pressure support trials, weaning parameters. And then a lot of times that nutrition doesn't start till 1500 or later. So it really adds up how little nutrition these patients get. And there's no one to blame for that. We need to do these procedures. We need to do these tests. And so what has been implemented here at Doyle and what's kind of recommended is what we call volume-based feeding. And so what this does is it allows us to adjust for the nutrition that was missed. Okay, so traditionally, we've always ordered tube feedings as rate-based feeding. And you can see that here where it says that osmolate 1.5 at 50 mLs per hour, just basic tube feed formula. The problem is if the tube feeds are off for 12, 16 hours, well, that's 50 mLs times 12 hours of tube feeds that we've missed. And so a new protocol we implemented in 2016, it's called Feed More. It's a volume-based feeding formula. It allows us to order a total volume for 24 hours. So it'd be 1200 mLs for 24 hours in the order. And then that gives the nurse the flexibility to adjust the hourly rate to make up for the times missed. And they have bedside charts that tell them what rate to run at based on how much was missed of the tube feedings. This is only used in our ICUs. It is not something used on our floors. And not every patient is going to be appropriate for this protocol. So usually the dietitian in their notes will kind of indicate whether this protocol is appropriate. So like my person in the CV ICU that I just talked about, who's had minimal nutrition, I put him on this protocol yesterday because it didn't seem like there was an end in sight. And then there's an order set for this. So it's a volume-based order, value-based feeding order set, and it takes into account like if their propofol doses increasing, if pressor doses, kind of different things, holding parameters. And like I said, it's not on the floor. Okay, and then other controversies of feeding in the ICU. Unfortunately, I don't have time to go through all of these. I'm more than happy to answer questions about them or, down the road or after this. Fiber in ICU patients on pressor agents is one concern, whether fiber is going to encourage more blood flow to the gut and if that's an issue in our patients. Effects of feeding on carbon dioxide levels in our non-invasive mechanically ventilated patients. And then immune modulating formulas and sepsis, which I kind of mentioned earlier. Okay, so going on to oral diets. So there's kind of some basic things to help optimize the patient's experience and also their nutrition if they're taking PO. One is ordering the least restrictive diet available. This is going to generally be the general diet. As sure as many of you can relate, when you're sick, you don't feel well and you really don't feel like eating. So giving them a general diet allows for more variety. Therapeutic diets, such some of those are listed on the side, really aren't intended for the acute hospital stay. They're more appropriate for the outpatient setting. Some of them like a low salt diet and someone with heart failure who comes in with fluid overload, that's going to be appropriate. But someone who comes in, let's say with CAD, hyperlipidemia, putting them on a low fat, low cholesterol diet, it's not going to change their lipid levels or do any benefit during their hospital stay. And so we really encourage keeping their diets as liberal as possible. Monitoring how often patient is NPO. I was co-signing a student's note yesterday. That patient had been NPO for a possible procedure every day for 7 out of the past 10 days since admission. Consulting speech therapy when appropriate if there's any swallowing concerns or patients' reports of dysphagia. And then providing oral nutrition supplements, but being realistic. And I'll talk about that in a minute. And then lastly, using calorie counts appropriately. Calorie counts are a great way to kind of get a ballpark of what the patient's eating, but they're really only going to be appropriate if we're going to do something about the calorie counts. So if we do a calorie count and show they're eating 60%, but the patient or team don't want a feeding tube, then that was kind of a waste of resources. Calorie counts are really tedious. They're time consuming for both the nurse and dietitian, because we have to calculate it all by hand. And unfortunately, despite our re-education, they're not usually done accurately. So it's a lot of guesswork of an estimating what the patient's eating. And so really, I think about, okay, is this calorie count going to result in an intervention? And if you guys ever want a calorie count, that's fine. Just, you have to page a dietitian or put a consult in for a calorie count, because the dietitian has to be the one to actually hang it and start it. On this side, you can see some therapeutic diets at Loyola. I kind of put when they would be appropriate, like a diabetic diet. If someone has a history of diabetes and is hyperglycemic, if they're chilling in the hundreds with their blood sugars, A1C 6.1, they probably don't need a diabetic diet while they're here. Renal diet's only necessary, again, if they have hyperkalemia or hyperphosphatemia. If they just have CKD, but their serum volumes are normal, there's no point of a renal diet. Okay, and so here's an example. Let's just say this is a 60-year-old with end-stage renal disease on dialysis, diabetes, comes in with shortness of breath. This is a cruel diet. It's mean. Renal, so 2 grams sodium, 2 grams potassium, low phosphorus, low carbohydrate restriction, and fluid restriction, 1,000 milliliters, which is like 1 cup at each meal. That patient, if I could show you guys what they could order, it's minimal. That's mean. So what we could do instead maybe is low sodium diet, may do 4 grams salt restriction. Maybe we could do a 1,500 ml fluid restriction. Of course, it's going to be based on labs, clinical data, things like that. Maybe we could liberalize the carbohydrates to 90 grams and see how their blood sugars react. And maybe their potassium's, borderline high, 4.8. We could do a 3 gram potassium restriction instead of the renal diet, which is 2 gram and low phos. So this is a nicer diet order for our patients. Okay, so supplements, I'm not going to go through these. Like I said, that formulary card I have in there does have all the supplements listed. These are the common ones we use here at Loyola. Most of the time, if a dietitian's seeing a patient, they're deciding if the patient needs a supplement and talking to the patient about which one's appropriate and what flavor. So you usually don't have to order these. We've already ordered it. If you put an order in, it just is overriding our order. All of them except for the Mighty Shakes and Magic Cup are lactose free and gluten free. So that's usually not an issue in terms of allergies or intolerances. And my biggest thing, what I tell people is when your patient isn't eating well or they don't have a good appetite or they don't feel good, ordering 6 supplements a day, like 2 Ensures, TID with meals, is not going to help them. They don't feel good. They don't have an appetite. Giving them 6 cans of Ensure is not going to be very unappealing to these patients. Very rarely does a patient need more than 3 a day. It's just kind of a waste of resources. Okay, and then briefly, I just want to talk about parenteral nutrition. So there's 2 types of parenteral nutrition. There's peripheral parenteral nutrition, and then total parenteral nutrition or central parenteral nutrition. And so, peripheral nutrition is going to be given peripherally. This is usually used as a bridge to TPN if we're waiting for a central line, or if the patient just needs some calories and protein, and we predict they're going to only need it for, 5 to 7 days and they're nourished coming in. The problem with peripheral nutrition is we're limited by its osmolality. It can only tolerate 900 milliosmoles via peripheral IV. And so that's only going to be about 680 calories that they get through peripheral parenteral nutrition. Also, peripheral parenteral nutrition doesn't have any electrolytes in it. So then you're still going to be having to replete lights outside intravascularly. And then our central parenteral nutrition or TPN is obviously through a central line, usually into superior vena cava. And this is going to tolerate higher osmolalities. We're able to put all the electrolytes, vitamins, everything like that and meet their nutrition goals in these patients. And so on this slide, you can kind of see when it's appropriate to do TPN. Most of the time we hold off for the first 5 to 7 days if we think they might progress either enterally or orally, just because parenteral nutrition has been associated with increased infection risk, length of stay, and total cost. It's a very expensive therapy. In someone who's high nutritional risk, though, very malnourished coming in, who we predict is going to be on PO for multiple days, it is appropriate to start TPN right away. And these are just some common indications. Whether it's they failed enteral nutrition, we are unable to get that enteral access, or if they have many, various GI dysfunctions that do not allow them to tolerate enteral nutrition. What happens is if you do want TPN, what you do is put in TPN consults. Those have to be put in by noon to get that TPN that day. We have dietitians. There's about 6 of us who write TPN. We will, write that TPN. We got to get those orders in by 1 p.m. Then a pharmacist reviews those, verifies those orders, sends it out to an outside pharmacy called CAPS that's in Chicago. They make the bag, it gets shipped back here for a hang time of 10 p.m. that night. And so we cannot do TPN if we don't have a confirmed central line access by 1 p.m. We will not order TPN because if we don't get that line, that's a waste of a bag. And then, if we don't think it's appropriate or we want to trial other interventions first, then we'll hold off on TPN as dietitians. Generally, in terms, people always ask me, do they need their own line, or can they use a double or triple lumen? As long as the TPN has its own lumen, so if it's double lumen pick, as long as the TPN has its own designated lumen, then we can use that, and the other lumen can be used for either blood draws or other drug therapies. And then just my ending notes. So here at Loyola, we have 17 inpatient dietitians, and then we have multiple outpatient dietitians as well. We're floor-based, so we just cover the patients based on what floor they're on. So if they transfer units, then they transfer to that dietitian, except for some dietitians are service-based, mainly the transplant dietitians like myself, where we follow our transplant patients no matter where they are in the hospital. We do have 2 dietitians on site for all weekends and holidays. There's their pagers there, and also through the AMS Connect app, which I think is awesome because we can just text instead of finding a phone to call each other. And then most importantly, looking for dietitian notes. So I think it's easiest to find your notes instead of through chart review and going into the current encounter in the hospital in the notes tab, and then ancillary. And that's where PT, OT, speech, social work, dietitian notes are going to be. I would say and this is just an estimate, but probably about 70% of patients are being followed by the dietitians, whether it's closely every few days or just kind of checking in weekly or so while they're here. So, before consulting or, changing things, maybe just looking at the last dietitian note, they could have just put a note in 2 hours before. And so people always ask me where to find them. And I think that's just the easiest pathway. The filters don't always capture all of us for some reason. And those are my references. And that is it. Thank you guys for your time. I appreciate it. I know I did have one question come in here. Do I have time to answer the question, Magda? Okay. So I did get a question. What is the benefit of pre-albumin over albumin? Which is a good question. So pre-albumin does have a shorter half-life. Albumin's half-life is about 21 days. Pre-albumin's 2 to 3 days. So pre-albumin is going to give us a more accurate assessment of the current interventions. So when people do want something to kind of trend or look at in terms of nutrition, I usually have them check pre-albumin with a CRP weekly, and we trend it. Okay. Okay, that's all I had. Does anyone have any questions? Thank you, guys. I appreciate your time. Sorry, I don't know how to stop this.